the video. So tendon physiology, we're going to start with that. So by Sathish Babu Giridharan from Physiofix Clinic and Physiofix Academy. So PDACE protocol. So this was a protocol which we were mentioning even in our Instagram handle. So what is PDACE protocol? It is not a treatment protocol, or it is not a structured protocol. This is a platform or design which helps us to come to a conclusion on how to manage a specific condition. So this protocol has been very easy for me to execute, learn, and apply in the clinical day-to-day clinical scenario, where it's very useful for us to understand the pathology, identify with the correct diagnosis, and then clarify whether the diagnosis was correct or not, and then execute with a proper protocol or modalities or treatment protocol, and then see the results come out. So the PDAC protocol, the P stands for the pathophysiology part of that. D stands for the differential diagnosis part of it. A stands for the assessment. C stands for the clinical decision making. And E stands for execution. So in this one, if you see, we have the pathophysiology in the first, differential diagnosis in the second, and the assessment as third. So why is it so? So why it should be PADCE protocol, right? So instead of identifying the pathophysiology, then we are going to do the assessment. No, this is not a clinical assessment tool. This is a tool for a physiotherapist to understand the pathology and to have a clarity in the clinical decision making part. So if you understand the pathology, you should understand what are the differential pathologies it is going to be there. So once you understand pathology and pathophysiology and the differential diagnosis, and then you start working on assessing the patient to find whether what you have done is correct or not. And then PAC protocol, and then we have to take after the assessment, then we have to do a clinical decision making. So on how we are going to manage this patient, and then we are going to do the execution part. So most of the workshops or seminar is only on the execution part, where they teach you a technique like manual therapy or dry needling or key taping or any other therapy. All the therapies and modalities come under the execution part. But before learning the execution part, or before the proper application of the execution part, it is very important for us to understand the other predecessors of before the execution. So this is what we are trying to impart to the physiotherapist in the future, for the future generations. So let's start with the tendon. So today we're going to start about the tendon pathology or tendonitis or tendinopathologies. So what is a tendon? So tendon is a dense fibrous connective tissue that connects the muscle to bone. Its primary role is to transmit the force generated by the muscle contraction to the skeleton, thereby producing movement and maintaining posture. You might have seen videos about bodybuilders working out really hard in the gym. They'll be contracting their muscles with a heavy dumbbells in their hands and making their biceps curl. You can see the biceps popping up, such a huge biceps. And that force from the biceps is transmitted via the tendon to the bone. That creates the elbow flexion in this case. So much of force is transmitted through the tendon. And you think how important a tendon is when you transmit the force. So most of our injuries or most of our strains happens when we try to transmit more force in a healthy or an unhealthy tendon. So when you try to put more force and transmit in a healthy tendon, it will be able to manage it. But when we do the same thing in an unhealthy tendon, it becomes very difficult. And tendons and ligaments, both the tendons and ligaments have some similar properties, but there's a small difference between tendons and ligaments. And it's very important for the joint movement stabilization, respectively. They are similar in structure and function, but metabolically, and they have a little bit of difference in the loading and other areas of pathophysiology. So you can see a tendon of tendon Achilles on the right side, and there is numbered in that one 1, 2, 3, 4, 5, 6. So the first one is the Achilles tendon or calcaneal tendon. And the second one is the lateral head of the gastrocnemius. Third one is the medial head of the gastrocnemius. Fourth one is the deep muscle, which is the soleus. And fifth one, so if you see the fifth one, it's the plantaris belly. So plantaris belly is a very thin, very, very small muscle, but they have a very long tendon going with the triceps surae. And then sixth one is the plantaris tendon. Then you can see the popliteus muscle, seventh one. So that's a diagonal muscle, which is also called as the locking or unlocking muscle. And then you can see the posterior nerve bundle, which is a tibial nerve, posterior tibial artery, and the veins present over there. And then you can see the medial septum of the leg. So what is the medial septum of the leg? So medial septum is a band of connective tissue which differentiates between the anterior compartment and the posterior compartment, or a medial compartment and the lateral compartment. So when you see a cross section of a leg or a thigh, we can see different muscles are placed in the different compartments, and the compartments are differentiated with thin band of fascia. So that is called as a septum. So septum is also connective tissue. We'll be speaking about some of the septums, which is called as a retinaculum near the joints, which actually anchors the tendons in position and helps to transfer the force in a particular direction. So remember this septum of the leg. And then the deep crura fascia. So if you see the 10th one, so the deep crural fascia differentiates the posterior part of the calf to the Achilles tendon. So that holds the Achilles tendon in position so that it doesn't move. And 11th one, you can see the peroneal tendon around the region. So this is to just show you how other structures are oriented. The fascia, you can see there is not much ligaments you can see in this image, but you can see the tendon, you can see the crura, you can see the septum. So all these are soft tissue connective structures which helps to transmit force, or it helps to uh, contain a particular muscle group in that specific area so that it does not move and injure. When we injure a ligament or injury or an ankle sprain, so it is not only the ligament or the tendon which is getting injured. There are other structures like the sclera, the fascia, the septum, the retinaculum. All these structures also get injured. And these structure also has a different composition metabolically as well as pathophysiologically in the healing mechanisms. So this is what we're going to discuss more in detail, not in today's session. Today I'll briefly explain what are the contents and structures. We'll have another future session about the detailed evaluation of this. So what is the composition of the tendon? The tendon is primarily made up of collagen, that too type 1 collagen. That's the most abundant protein, providing high tensile strength and creating the hierarchical structure of the tendon and the ligaments. So type 1 collagen is the primary one. So there are other types of collagen, which is type 3, type 5, type 6, and type 7 collagen, which are also present. So what is a collagen? Collagen is a protein molecule which which links with one another and forms a long chain of structure. So that becomes a part of a fascicle. So when the fascicles join together, a group of fascicles which join together, it becomes a bigger bundle. So a group of bigger bundle of fascia fascicles, when it's combined together, that forms the tendon. So in that one, primarily the collagen is there. Collagen is the ground substance or the protein, which is a non-living thing. It's a protein is a structure, but it is provided by the muscle or the cells, and it is present in the tendon. There are other living structures also in the tendon, as well as there is some amount of blood vessels and as well as a nerve supply to the tendon. So then the proteoglycans are there. So proteoglycans, which is also called as glycosaminoglycans in the knee or in the joint or anything. So these includes decorin, this includes fibromodulin, biglycan, lumican, which helps to organize and lubricate the collagen fiber and the bundle. So there are different names. Don't be very scared with the names. So each are different types of protein molecules which has a different function in that tendon, and it helps to keep the tendon intact. Some helps to do a cross-sectional, some helps in a longitudinal. There are differences in the tendon. this goes more deeper and deeper and deeper if you go study around it. But for us, if you can understand this much to start with, will be a good start. So from here, we'll share with papers and research articles where you can read more about the other fibers and pathologies where certain proteoglycans or certain type of collagen are deficient, or it has you have a pathology or genetic mutation where certain amount of collagens are not able to be processed. For example, if you have a genetic mutation where type 1 collagen is going to be very difficult for you to produce, then think how it is going to affect a tendon injury. Similarly, there are small amounts of other composition of collagens, proteoglycans, and other structures. When there is a pathophysiology around genetic mutation around that, which affects this, it also affects the tendon pathology and healing. And water. A significant composition of tendon is made up of water, which influence tissue stiffness. So water, when it is held in a very tight structure, it gives a little bit of tensile strength around the region, but also some amount of flexibility. That's what the water helps us. Even though the water is there, it's very significant how the water is positioned in the tendon. We will be seeing some images later on. And fibroblasts. So these are the only cells which is present in the tendon, tenocytes or fibrocytes, which are found within the extracellular matrix responsible for synthesizing and maintaining the tissue. So these tenocytes or fibrocytes only produce the type 1 collagen, the other type 3, type 4 collagen, all the proteoglycans, and the retaining the water. So if the number of tenocytes is reduced in the tendon, and that means the ability of the tendon to heal after it getting injured is going to be very difficult. As a person is aging, the number of tenocytes and fibrocytes in the tendon slowly starts depreciating or reducing. So that's why you can see degenerative tendonitis, or for example, in the age person, supraspinatus, and there would have not been any fall, no injury, no much workout or pathology, but the tendon degenerates and the pathology, like tendon supraspinatus tendon goes for a tear. Why it goes for a tear? Because the fibrocytes have reduced, and there are a lot of research articles on how much the fibrocytes are important for it and what ages and what specific category of population the fibrocytes gets damaged and how metabolically important it is. So, for example, higher levels of insulin and diabetes, how it affects the tenocytes or fibrocytes, and that fibrocyte affecting is slowly going to do a tendon degeneration that you can see in the diabetes and frozen shoulder cases. So these cells are very important for synthesizing the matrix. So when the matrix is not available, the tendon goes for a degenerative pathology. So hierarchical structure of the tendon. So first one is the collagen molecule, which is a very basic unit which self-assemble into a triple helix polypeptide chain. So that is a protein, so collagen. And then when the collagen stacks up into a different, like a larger molecule, it's called as microfibrils. This collagen molecule stacks and assembles into a microfibrils, which is a very thin filament. So these microfibrils convert into fibrils. So many microfibrils organize into a large fibril. So the organization will be more linear along the length of force transmission is what it will be there when it's a healthy tendon. When the injury happens and when the tendon starts healing, these microfibrils or first from the collagen to the microfibril to the fibril deposit happens in a very haphazard manner where it looks like the force transmission is not happening evenly between the proximal attachment or along the length of the tendon, and the force is distributed a little unevenly. That creates very difficult for the tendon to transmit the force, and sometimes it creates re-injury also. That's why it is very difficult after a hamstring tendonitis or tendo Achilles. This microfibrils and fibrils deposition is very important for us. And one fantastic tool which we have is something called as ultrasound. So ultrasound helps us to mobilize or improvise the microfibril deposition into the linear pattern so that the recovery of the tendon is much better. There are a lot of research papers on this. So we just go do ultrasound over the patient, but we don't know what is happening around that patient from the tendonitis. The ultrasound actually improvise the microfibrils and fibril deposition in the tendon which in turn helps to improvise the force transmission as well as reduce the pain. So there are so many different ways it ultrasound can help to relieve. Even a massage can work around that. A gentle massage, IASTM tools, and offloading the tendon with proper kinesio taping. All those strategies help, but you should understand what is happening with the injury before that. And then the microfibrils into fibers or fascicles. So the fibrils aggregate to form larger collagen fibers and bundles, which is called as fascicles. And these fascicles, bigger bundles. So these bundles are then surrounded by connective tissues. So these are the connective tissues which you saw in the tendon. So the bigger connective tissue forming a larger tendon or the ligament structure. So this is a longitudinal cross section of the tendon. So what is a longitudinal cross section? So they have taken a tendon. So it's like a tendon, like a part. So just a minute. So if they have taken a tendon like this, and then they have cut the tendon and sliced it horizontally, longitudinally, and you can see the arrangement of the fibers. So you can see this is a tissue stain. They use hyoscine and eosin. So this is a stain which they applied on the tendon so that we can see different components of the tendon. You can see how linear the tendon cells or the fascicles are placed over each other. This is a very healthy tendon. And over the edges, you can see small changes around that. So these are you can see more number of cells at the periphery of the tendon and very less number of cells in the center of the tendon. And you can see there are certain pockets where there is small shade of gray or blue. So these are all fascicle bundles, and around the bundles, the cell quantity is more, and that is why it is looking like that. Is it okay? Can you see that? And if you take a small cut section from the tendon and zoom it a little bit and see, this is what you see. So you can see the fascicles arranged in the linear pattern, and it is looking a wavy pattern. Can you see that? So the wavy pattern of deposition shows that there is no load in this tendon. But when you give a load around this tendon, this wavy pattern will disappear. Since they have cut the tendon and then they have dissected along the longitudinal cross section, and then they have placed it in a very like no tensile forces there around the tendon, this wavy pattern starts appearing. Same way, if you cut the cross section of the tendon. So next one is the perpendicular cross section of the tendon. So when you see a perpendicular cross section of a tendon, you can see the tendon into different fascicle and bundles, and you can see the connective tissue. There's a wide area of connective tissue, and there are differences in the smaller areas. So you can see this, right? So you can see a wide connective tissue covering the tendon over here. So that's one fascicle over here. And there's another fascicle covering over here. And you can see a small blood vessel in between the fascicle, which helps to work around it. And you can see a smaller blood vessel around the periphery. So that will be the nerves and blood vessels around the gel. There's not, and you can see again blood vessels and nerve supply around the edge of it. Can you see that? Am I audible, guys? Yes. So you can see a small changes around that region. So that's a cross section. So when you go a little bit detailed, so if we take a deeper, the small area around this, and if you zoom it, you can see that. So there are inside the bundles, there are multiple fascicles. So the fascicles are covered by the small fascia. And on the periphery, you can see the blood vessels and other cells which are stacked. Okay, next we're going to talk about the ligament. So what is a ligament? Ligament is the same dense connective tissue which connects from one bone to the another bone. So in this video, in this image, you can see the ligament over here. That's a posterior, that's a PCL, posterior cruciate ligament over here. So that's a fibular collateral ligament on the lateral side. That's a popliteus tendon. This is a biceps femoris head which is cut, and that's a fibular head. So what is a ligament? Ligaments are short band of tough, flexible tissue made up of lots of individual fibers which connect the bones of the body together. Being a dense type of connective tissue, ligaments can be found connecting most of the bones in the body. So the ligament is a very short tough band. If you see a tendon are long strands, but ligaments, you don't have a long ligaments. They are very, very short and it's connected to the bones around the skin. And tendons, if you see, one end of the tendon is attached to the muscle. It's a different orientation. So the you can see the perimysium, epimysium, all the muscle fascia that comes and ends into the tendon, and they come make from the cojoint tendon, also muscular tendinous junction. And at the bone where it is attaching to it, it's different. So the tendon attaches one side to the muscle and one side to the bone. A ligament is not like that. Ligament attaches both sides to the bone, but it's a very short, flexible connective tissue. So while the ligament appears as a single structure with joint movement, so we consider like lateral collateral ligament. So anterior band of the talocalcaneal ligament. So we consider it one ligament. Even though it is one ligament, there are multiple fascicles or bundles in the same ligament. With the joint movement, some fibers tighten. So it is like a cord or a rope. So if you pull the cord or rope, so if you just consider like so you're done the weight training or strength training, so you do a cable which is very thick and multiple fibers are there. Try to hold the cable and try to bend and see. You can see the one end of the cable just pulling, the other end still soft and supple. So similarly, ligaments have multiple fascicles. So when there's a load going on one segment, the particular angle pulls the ligament into a certain areas, but the other areas are still loose and much more free. So that's what I want to say. Well, the ligament appears as a single structure with a joint movement. Only some fibers appear to tighten or loosen depending upon the bone position or the bony position and the forces that are applied, confirming that these structures are more complex. So it is more complex than what we are thought. So when we consider an inversion injury or an ankle inversion injury, when the patient comes to me, I ask them, how did you fall? Can you demonstrate how much did it go? So that tells me an idea of where the load has gone, other than the lateral area, medial. There's a small change in angulation. So based on that, if you see the injury and the inversion sprain around the ankle, you will be able to make up, okay, to this extent where the load has gone and which ligament could have injured. Just a rough idea. And then when you palpate the ligament around the tibia, you can see mostly the anterior band will be involved. The middle band will not be involved. So you can test and see. So you can do a small anterior or posterior draws test and see if it's anterior band or middle band or posterior band. So the movement, the structure which is injured, and the assessment should correlate. Then that confirms only the anterior band or middle band or posterior band is involved. Just 1 minute. Oh, what are the parts of the ligament? Yeah, okay. Parts of the ligament? Yes, there are two different structures in the ligament, which is very important for us to learn. So far we have thought ligament as one structure. When it's injured, it heals. No. So there is the outer layer around the ligament, epiligament, and there's the inner core structure in the ligament. The blood flow is mostly on the outer part of the ligament, and the inner part of the ligament are devoid or is very less blood flow is there. So when there's, I will go ahead. Protein fibers. Ligaments are mostly made up of woven strands of protein, especially collagen and elastin. Some of the some have more collagen for toughness and some has more elastin for elasticity. So depending upon the area of injury, this is going to differ from ligament to ligament. When the forces are put stress on the ligament, some strands appear to tighten while others loosen. This is what. And the epiligament. So this is the center portion of the ligament or the protein fibers or the primary ligament which is there. And there's something called as epiligament. Epiligaments are the outer layer of the ligaments, which is that's why it's called as epi on the outer layer. This layer has many blood vessels and nerves in it than the inner part. It seems to play an important role in detecting and repairing injuries to your ligament. Blood vessels feed this tissue as they repair. So, for example, if you have an injury in the triangular fibrocartilage, so the beauty is the triangular fibrocartilage ligament, when it gets injured, you can see it's a T-shaped ligament around the wrist, and the blood flow goes from the periphery, from the outer margin into the inner. So when the tendon injures or get ruptured, similar to a scaphoid pressure. So when the blood flow is restricted, that's why the scaphoid goes for a non-healing or unhealing. There is a healing of the scaphoid gets affected. Similarly, in the triangular fibrogram, when the strands are affected, when the outer bands are affected, the blood flow to the ligament is very much reduced. So that divides or that delays the healing process of the ligament. That's why when we see a triangular fibroglad ligament, the rehabilitation protocol is different, and we need to stabilize that ligament for a longer period of duration compared to the other ligaments. So that's why the difference is there. So histology of the ligament. So when you see, so L is the ligament, EL stands for the epiligament. So this is a normal morphology or a very normal ligament over here. And the arrow marks which you see are the cells similar to the tendon, which produces the elastin and the proteoglycans in the ligament. And there are some amount of adipocytes or fat tissues and other different structures in the ligament. So ligament structure and composition. Primarily, there are few fibroblasts in the as the cells which are responsible for the matrix synthesis, interconnected via cytoplasmic extension, forming a 3D network. So the cells are there. The fibroblast of the ligament is important for the matrix synthesis, and the primary structure is mostly proteins. Is collagen, as collagen, which is called into elastin also. So the collagen membranes align along with the ligament axis, which crimp pattern. So what is the crimp pattern? Crimp pattern is like it's like a flexible or like a woven pattern. Um, if you go to a supermarket in those days and all, there'll be a small sack where they'll want to put vegetables or eggs and all that. So they'll put a like knitted bands. If you see like orange color knitted bag will be there. So when you lift the bag, you can see the structural integrity how it is. So that's a crimp pattern. And most of the times now you get the Amazon or any package delivery. So if you can see a bubble wrap around that, and nowadays they have removed the bubble wrap, so they are using a small cardboard pattern which is dissected. So if you pull the cardboard, you can see a very a crimp pattern around that. So that gives a little bit of tensile strength for the ligament. It gives a little bit of allowance, but it still smooths the strength around it. So when the uncrimping happens, load allows us to a little bit of elongation of the tendon. So biochemistry is two-thirds of the ligaments is primarily made up of water, and one-third is made up of solid substance. And in that solid substance, type 1 collagen, which is 78% of the dry weight of the ligament. And then proteoglycans. Proteoglycans are less than 1%. Primarily, it is elastin and glycoproteins. Glycoproteins is proteoglycans, we call that as. And then strength. So strength is primarily from the collagen fibers, which forms cross links. In tendon, if you see the cut section, it was linearly arranged to distribute the weight. But in the ligament, the cross fibrils are cross-linked with each other, which gives strength with age and which gives ligaments its high tensile strength. So when you compare to a tendon, ligaments has much more higher tensile strength to support the joint. So ligament. So these are the collagen. So you can see the collagen in the crimp pattern. So it is not, you can see the helical structure over here. So these are different types of collagens which are arranged with each other. So this crimp pattern, it has a little bit of allowance around the structure. And you can see the small blue molecules. That's the cross bridging between the collagen tendon. That helps to keep the collagen molecule in contact with each other, so that even though it has allowance, it has much more tensile load capacity. And these are the glycosaminoglycans, primarily the chondroitin sulfate and keratin sulfate. That's a proteoglycan over here. You can see the protein core and the hyaluronic acid here, and keratin sulfate and such glycosaminoglycans in the ligament. So it is only less than 1%. Primarily, it is the collagen, 75% of the weight, and there are some amount of cells as well as the glycosaminoglycans in the ligament. So this is a very important area. So how a ligament is attached. So tendon, we saw one side of the tendon is attached to the muscles, and this is called as a musculotendinous junction. The other side of the tendon is attached to the bone through the periosteum. That's a very standard one. But in the case of ligament, the different areas of the bones are going to be very different, and the attachment of that specific ligament is going to be very different. So we can see different types of ligaments, tendon to bone interface. First one, if you see A, so that's a ligament or a tendon. So in this one, both we are going to see ligament or a tendon. So you can see UFC and CSC. So calcified fibrocartilage, uncalcified fibrocartilage. That's the difference on here. And we can see the interdigitation. So the interdigitation can be shallower or it can be much more deeper, depending upon how hard it is going to hold through the. And then you can see the subchondral bone and the trabecular bone over here. So the epiphyseal interface, the first one is the epiphyseal interface with cartilaginous bone connection. So the tendon or the ligament is connected to the cartilage a little bit. There's a small layer of cartilage, and the cartilage in turn connects to the bone. So this kind of particular cartilage or ligaments you can see in the ribs over here, costal vertebra. So there is the cartilage over here, the bone forms some amount of ligament forms, and tendon also attaches over here. The second one is diaphyseal interface with a fleshy attachment to the periosteum. So in the B, you can see the ligament tendon, and there's directly attached to the periosteum and the bone. There is no in between epiphyseal cartilage. So there's no cartilage around this region, and the tendon or ligament is directly connected to the bones. Third one is diaphyseal interface with the circumcised tendon attached to the bony crest. So in the third part, there is no periosteum also. So the diaphysis directly interface with the tendon attachment. So you can see tendon directly attaching with the bone. So, so when we go in detail, for example, tendo-Achilles has a different orientation of attachment. Similarly, the lateral collateral ligament has a different orientation of it. The biceps tendon has a different orientation. So when it's attached to the periosteum, the pathology or the recovery is going to be a little bit different. When it's attached, going to be the cartilage or subchondral cartilage, when there's a cartilage connection, the cartilage is also going to get injured and the healing time is going to be different. When the diaphyseal interface is there, the pathology is going to be different. So if you understand what type of attachment a biceps tendon or the supraspinatus tendon is having that, you will understand how to work on the recovery. That's why we are focusing on the pathophysiology part of the tendinopathy workshop this time. And then when you see the ligamentous part, so in this, the ligamentous endothelium is half the way it is direct interface, and there is somewhere indirect interface with a small amount of cartilage. So both are present. So in the D, if you can see, there's a direct some amount of fibers directly attached to the bone, and some amount of fibers indirectly attached to the bone via a cartilaginous growth. So these are the type of ligament and tendinous attachment from the ligament or tendon to the bone to transmit the weight. So just a curiosity. So which will be the most amount of what's it? Force transmission? Large force transmission can happen through which type of junction like this? A, B, C, or D? Can anybody answer? Hello? Anybody can unmute and answer? Okay. I guess we have most passive listeners. Okay. Maybe full screen. Is my screen visible? Sharmila? Okay. So the next is the ligamentous connection distribution. So what type of structures or what are the contents in this? So if you can see the four different type of structures which you saw. So in the ligament, it's mostly the collagen. Collagens are type 1, type 3, type 4, type 5. And proteoglycans. In A, you can see what are the different type of collagen content present in different type of type 1 collagen is primarily present in bone and the tendon. But you can see around the cartilage area there are different type of collagen, and here there's a different type of collagen. Second one is proteoglycans. So in B, if you can see the Versatin dicorin is a primary collagen proteoglycan in the ligament and tendon, whereas keratin, chondroitin, dermatin, sulfate, aggregain, decorin, cartilage, these are all present in the cartilage junction. And in the bone, it is primarily the alkaline phosphate. And in structure C, you can see the mineral content. There is no much mineral content in the ligaments and tendon, but as we see in the bone and the cartilage over here, there's a phosphate content which increases as we go into the bone. And the blood vessels. So the blood vessels are there throughout the ligaments, towards the cartilage, as well as in the bones. So retinaculum. So what is a retinaculum? Retinaculum is a very dense connective tissue band found around the joints like wrist and ankle, stabilizing the tendon, preventing the bowstringing during the movement. So we saw a different, so interfascicular septum was there, septum, the retinaculum. These are all fascia bundles or fascial planes, which helps to anchor, stabilize, or prevent the bowstringing of the tendon during the movement. And this also is going to have different contribution. So it consists of layers of structures rich in collagen and elastin. So in tendon, you saw there was very less elastin around them. So mostly it's collagen and there are other ones. But in the ligament, there was collagen as well as elastin, some amount of elastin, which gives a little bit of allowance in the tendon, in the ligament, even though it's strong, but it can move a little bit. But in the retinaculum, it has more number of elastin as well as there's a lot of nerves which is present in the retinaculum. Since it's going to be a structure which is just going to hold, there's a lot of sensory nerves around the retinaculum. So when the retinaculum get injured, it is going to be very painful because it transmits more sensory input to the brain as a which can be perceived as pain sensation. So the why the nerve is there. So all these collagen, elastin, and nerve provide both strength and sensory feedback to the brain. Compared to the ligament, retinacula are more elastic and innervated. Injury or abnormality in the retinaculum can disrupt tendon function. So when there is a retinacular dysfunction, it will not allow the tendon to transmit the force in an even pattern. So for example, when there is an ankle inversion sprain, you can also injure the superficial upper sorry extensor retinaculum around the ankle. So when the retinaculum is injured, it's very difficult for you to transfer the force via the tendon, and the tendon starts swelling, inflamed, and that causes pain. When we treat, if we treat only the ligament, it will not be enough for us to load the patient or to do weight bearing much earlier. So we need to support the retinaculum also. Taping can be one of a very good technique where you can work or support the retinaculum to a certain extent on by taping and enhance the recovery process from the patient. So injury or abnormal retinaculum can disrupt tendon function, highlighting its crucial role, distinct role among the connective tissue. So most of the times when we see a tendon injury or ligament injury, but we neglect the retinaculum or septum or the facet, intermuscular septums and other areas. These are also connective tissues, highly innervated elastic connective tissue, which gets injured very easily and needs a proper rehabilitation to recover them. So patellar, okay, so I'll show you a patellar retinaculum. So you can see in the cross section over here, that's a patellar tendon, and this is a cross section. You can see the lower end of the femur over here, and the patellar tendon is cut section over here. On the lateral side, the blue one, it is a normal patellar retinaculum. You can see the structures are layers of tissues, much more clearer and denser, and it is linearly connected. But on the right lateral side, so that's a medial side. On the lateral side, when you see, there's a disruption in the retinaculum. So this retinaculum is a pathological retinaculum, and you can see the alignment of the structures or the cells is not very linear, and it is clubbed with one another. So it is forming a very dense band of tissue, which is not going to allow the patellar tendon to transmit the force much easily on the. So it's not going to give stability on the lateral side. So the medial side has to give a lot of stability. So in this case, even though the MRI shows there is no patellar tendon injury, but if you palpate lateral to the patellar tendon and the retinaculum is injured or involved in an injury, the pain is going to be persistent around the patellar tendon. So how to assess or differential diagnosis, we'll take it in the future sessions. So this is a knee specimen cadaver from a cadaver of an 86-year-old man with a focal defect in the lateral patellar retinaculum. So that's a photomicrograph of a gross historic specimen with histosine and eosin showing correlated defect between the lateral patellar area noted by the dotted brace. You can see the dotted brace over here. That's the injured. So you can see the healthy lateral retinaculum and healthy lateral retinaculum. This also we can do a lot of therapy. So one is we can stabilize the retinaculum, we said with taping. So we can help to do a deep tissue or soft tissue release and allow the fascial bundles to recover. We can use ultrasound therapy to improvise the blood flow around the fascicle or the retinaculum and promote the healing around the region. So retinaculum, this is a pictorial representation of retinaculum. So you can see the ankle injury you see here, that's normally the ligament over here. And this band of white tissue. So this is the superficial extensor retinaculum. So this is the inferior extensor retinaculum. So these two retinaculum are important to keep the extensor digitorum tendon and other tendons intact so that they can transmit force. When an ankle inversion injury happens, if it's a more anterior inversion, you can see this inferior extensor retinaculum can get injured very, very easily. Do we treat an extensor retinaculum? No, most of us don't even understand what is a retinaculum and what is its function, so we neglect that and we try to do ultrasound around the malleoli, but still there's going to be pain, discomfort around for the patient. So this is a small video, so you can see in this video over here. I'm going to play this, so you can see. Okay. Back. Okay, I will play the video in the last. It's a very interesting video where I will show you the demonstration. So what is the difference between a tendinosis and tendinitis? So far we saw what is the tendon, what are the contents in the tendon, and what is a ligament, what is the function of the ligament, what are the contents of the ligament, what is the retinaculum, what is the function of the retinaculum, and what are the contents and the histology of all three we saw. In tendinitis, is mostly inflammatory. During acute injuries, the tendon gets injured and the inflammation sets. Inflammation is part of the healing. So tendonitis is mostly healing. And tendinosis is mostly degenerative. As I mentioned about the supraspinatus tendinosis of a senior citizen who had no history of fall injury, but the tendon starts degenerating. So the degeneration happens within. So in tendinitis, you can see a swelling around the tendon. When you palpate, you can see fields and field of swelling. But in tendinosis, there's no swelling, but there's a degeneration around the tendon. This is a very old terminology which has been used. So they have come to a conclusion to use one common terminology as tendinopathy. So it is not always inflammation present in the tendinitis, but in tendinosis there is always degeneration present. Sometimes it's combination of both. So it's a good to have one common terminology to be used by the scientific community as well as the medical community. It's called as tendinopathy. So if you can, whenever you write a diagnosis, you can mention as right supraspinatus tendinopathy instead of tendinosis or tendinitis. And in that tendinopathy, you can mention because of its inflammatory reason, you can mention it as tendinitis. If it's degenerative, then you can mention it as tendinosis for your clinical decision and communicating with the other therapist. So in tendinitis, You can see, so as I mentioned, there's swelling. So you can see the collagen fibers, the myofibers, the tendon over here. It's attached to the bone. There is inflammation of the tendon, which is caused by straining or tearing of the tendon fibers. But in tendinosis, you can see there's a big amount of bulk over here. So, but in tendinosis, the bulk slowly is reduced. Tendinosis is a chronic injury caused by an accumulation of small tears over a period of time, so that the tendon have failed to heal. So there's something called as optimal loading. So when we see tendon healing or pathology, we need to do something called as optimal loading. So we'll be talking about that when we take workshops in the future. So tendinopathy. So tendinopathy, as I mentioned, is a very common terminology to mention about both. So when the tendon, the previous slide which we saw, tendinitis is inflammation and tendinopathy, but micro tears. So every time there is a micro tear happening, there is a tendinitis. So there's an inflammation, and the healing mechanism has failed. That's leading to damage or disruption of the fibers around that region. So that disruption of fibers slowly leads into degeneration. So that's what is called as tendinopathy. So in tendinopathy, both wells have inflammation because of injury, smaller or micro injuries, as well as degeneration happening together. That's the common terminology we'll be using. That's why the name of workshop today content itself was tendinopathy. So this is a very interesting pathogenesis of how a tendon gets injured. So we have a short here. I will quickly go through this, and we will have further when we talk about tendon healing or how to work on tendon pathologies with physiotherapy and what are the modalities to be applied. We will talk in detail about that there. So for the tendon and pathology or pathogenesis, the intrinsic factors is age, body weight, nutrition status, gender, anatomical variations, joint laxity, systemic diseases, muscle weakness or imbalances, and vascular perfusion. These are all the intrinsic factors which is within us, which can affect the tendon. There are extrinsic factors, which is occupation, the sport, what type of equipment which you use, how much physical load we are giving, and the environmental conditions. So intrinsic factors as well as extrinsic factors can be modified to offload the tendon. So you can see structural weakness in the tendon can happen both because of intrinsic and extrinsic factors, and that leads to shear mechanical stress applied to the tendon. That leads to small micro tears within the tendon. So this micro tear initiates an inflammation and healing process. So the inflammation, so there are three phases primarily in the tendinopathy or tendon injury. The first phase is inflammation, the second phase is proliferation, and the third phase is remodeling. So this is for the acute injury. In a very chronic injury, the remodeling, the proliferation phase extends to a much longer duration. So till then we work on. So if the shear force is very excessive, with or without structural weakness, that can lead to a tendon rupture or a tear in the physical tear in the tendon. So there is a micro tear and there is a physical tear. Most of the classic cases which we see is a micro tears within the tendon. And for the tendon ruptures, there are a number of YouTube videos where you can see the person is really pushing hard working and the tendon ruptures and the biceps curls up around it. Even for the hamstrings, there are a number of videos. So that is to be taken, the pathology will be corrected only by a surgeon who brings the tendon bone together and then sutures them. So that's completely a different area of work. So in coming to this inflammatory phase, the inflammatory phase is acute, it is called as tendinitis or acute tendon inflammation. So that increases the capillary permeability within the fluid which exudates and leads to the swelling. And that also increases the nociceptive activation. So the nociceptive activation is sensed by us as pain sensation. And the second phase is the proliferation phase. In the proliferation phase, the angiofibroblasts, the new blood vessels, as angio means blood, fibroblastic activity. So new blood vessels start forming, hyperplasia, new vascularization, new blood vessels form, and nerves grow within the tendon during the proliferation phase. So from the proliferation phase, the nerves within the tendon are easily activated because there is neovascularization, new nerves are forming. It activates the nociception, which leads to localized pain on palpation. So when you palpate the tendon, it's going to have pain around palpation. So the other way is the pain on the tendon during loading. So either palpating or loading, these nerves or nociceptors are going to sensitize that. Then second one is the collagen reorganizing during the proliferation phase or the remodeling phase. When the remodeling happens, the proliferation. So all the collagen deposits in the linear approach, all the type of collagen. So primarily it's collagen is type 1 collagen, but after the injury, type 3 collagen forms more. That is makes the scaffolding around the ligament or tendon, but the amount of force load which it can transmit will be comparatively less to a type 1 collagen. So that laying of the collagen and remodeling causes thickened tendon, compresses the nerve, and inhibits the movement. Sometimes it inhibits the movement, which leads to stiffness around this region. And there's nodules. So when you palpate the tendon and injured, you can feel a bulk or swelling around the tendon. Nodules of thick collagen catch during the movement. So if this kind of thick collagen catch happens in the tendons of your fingers, we call that as a trigger finger. So that leads to a lot of crepitus. And when the trigger finger, when the annular ligament over here is locking that, you can get like unlocking sensation or crepitus around the region. So when there is insufficient healing time and return to activity before, it breaks down, leading to more increased collagen content within the tendon and less strength. So all these factors leads to tendinosis or degenerative process within the tendon, which leads to inflammation and swelling. But tendinitis is only in the acute phase. The tendon can get rupture as well as tendinosis. So this was published in January of 2016. So there is a guideline called the Caligari guideline. You can go to the internet and get the details. So this was published properly. So this gives us a brief idea of how the tendon gets injured, where the healing happens, and what we need to do. So when you understand this mechanics very easily, and when you assess a patient, you have to put them in which phase they are in. And if you know which phase they are in, then you know how to manage them better. So similarly for the ligament injury, so there are three grades of ligament injury: grade 1, grade 2, grade 3. Grade 1 is small stretching tears around the grade 1 sprain. In grade 2, there's a large but incomplete tear. In grade 3, it's a complete tear, but there's discontinuity around the tendon. So grade 3, they have to go for surgery or they need to keep the joint immobilized for a longer period of time. It can be considered like a fracture, and the treatment should be done how you treat a fracture. So you can see the for the ligament injury, we're going to cascade and go through. This is a very recent publication from 2023. So we are considering ankle ligament as an example and trying to understand this pathophysiology. The same applies to any other ligament of the body. So ankle eversion beyond the normal range causes excessive stress on the deltoid ligament. That's when there is an eversion injury, is a medial collateral ligament. And when there is an inversion injury, that's a lateral collateral ligament. So medial deltoid ligament and ankle ligament. So in both the cases, the collagen fiber ligaments rupture. So that's called as a low ankle sprain. That leads to, we have to see whether there's associated fracture or malleolus or subtalar joint, if there is any bony pain or instability around that region. So when the lower ankle sprain happens, we need to identify whether it is grade 1, grade 2, grade 3, as we saw in the previous slide. In the grade 1, there is a minimal ligament disruption. There is no laxity in the joint. So the patient will have an inversion sprain. It will be painful for 1-2 days. The patient would have recovered. Loading will be much more easier for them. They will be able to walk, move. There's no instability. In a grade 2 injury, it becomes an incomplete ligament tear where there is some amount of joint laxity. So you can see subluxation of the talus within the anterior forearm. So when you force the heel, there will be some amount of subluxation. So subluxation is a terminology which is used by the Mulligans or any method or physiotherapy terminology. Similarly, if you see terminologies in chiropractic and osteopathy, they have different terminologies for the same thing. So that leads to when you do an anterior draws test, when there is a subtalar subluxation there, that will show positive. So that will lead to recurrent sprain. Okay. So anterior draws test is positive. When there is a complete tear, there's a there's you can see the very big giant laxity because it's complete tear. The ligament is not supporting the ankle at all, and the laxity is going to be very high. That leads to mechanical and functional instability. So when there is a mechanical and functional instability, there's going to be a recurrent sprain. So if you see a patient with ankle motion sprains, they will have a repetitive injuries. So if they have been into a clinical practice for some time, they'll come with the same ankle motion injury repeatedly for a few times. And I have seen patient with chronic ankle injury for years together. They'll have pain there years together without any recovery at all, and they've been started living with it. So when there is a recurrent pain, there is synovial inflammation and hypertrophy. That's the joint which gets injured. There is a decreased ankle joint space, which leads to ankle impingement or compression of the bony structures. And when synovial inflammation happens, there's a lot of remodeling, collagen, and bone deposit happens, which leads to degeneration, osteophytes, and subchondral sclerosis. We would have attended our radiology workshop, you might have understood what is an osteophyte and the subchondral sclerosis because of the degenerative changes that leads to chronic ankle instability. And the instability again leads to impingement. That becomes a vicious cycle around this region. So now in the low ankle sprain, we saw how the grade 1, grade 2, grade 3 injury leads to the pathology. So what are the other recovery mechanisms? The first one is the recruitment of inflammatory cells to the damaged area. So there is an inflammatory response. A lot of interleukins and other substance get produced there that produce inflammation around that area. It will help you to increase the local pro-inflammatory cytokines. IL-6, IL-1, all those are the pro-inflammatory cytokines. That improves the capillary permeability and vasodilatation to the damaged area. That's why there is swelling. So there is a mechanism how the swelling happens. And if you see swelling constantly around the ankle, around the region, always think this mechanism is there. So there is always some inflammatory cells around the damaged area, creating local inflammation and cytokines that increases the capillary permeability, and there's always vasodilatation and swelling. You could have seen some ankle injuries very chronic, and the swelling will be there constantly. There would have not been reduction. That means they have not given enough rest and they have not worked on improvising this mechanism. There are other disruptors are also along with this mechanism which can do that. And there is local blood vessel tear when the blood leaks into the surrounding tissue, which leads to bruising and swelling. So in the high grade ligament injuries like grade 2, grade 3, sometimes the blood vessel gets injured. Even in grade 1, sometimes there will be a blood vessel injury, and you can see a bluish black discoloration around the injured area. That means the blood vessel is also involved, which leads to bruising, swelling, leading to focal tenderness over the ligament. So that leads to increase. So when all these the blood vessel leak and increased capillary leads to nociceptive activated by trauma and inflammatory. So nociception is the sensory input given by the injured area, and the nociceptive, when we take on when our brain processes the nociception, it perceives it as pain. So a pain on injury and weight bearing, and that's the antalgic. The gait changes bearing. So when the damage of the mechanoreceptor, there are mechanoreceptors around the muscles surrounding the ankle joint, so around the tendon. You can see the blood flow and the nerves, which is around the epitendon, they all get damaged, which leads to impaired proprioception and neurovascular momentum. This is why even once the ankle injury happens, if this mechanism or the proprioception or neurovascular control is not treated or not given to the patient is going to have repetitive falls and injury. So an ankle injury, when we have a patient, We don't only work on improvising swelling relief. We have to start working on proprioceptive training for those clients so that we can minimize the future falls and injuries. Got it? So it looks very complicated, but when I explain, you can understand the pathology. Okay, thank you very much. It's almost 7:30, so we planned for a 1.5 hour seminar, but we try to concise and do it so that we can have clinical discussion after that. So people who likes to join into the clinical decision making group, you can take a screenshot of this QR code and scan and join our WhatsApp group in the clinical decision making, where we'll be sharing more information about the tendon and tendon pathologies. So this is a gist of what we did today. In future, we are planning for a workshop which helps us to plan how to work on rehabilitation of this kind of tendinitis, ligament injuries, and the retinacular injuries. Thank you. And any questions? I'm going to stop the screen sharing now. Any questions? Yes.
Sir, actually, I didn't go through the webinar today because I had a patient repeatedly. Sir, can you please share me the recording video?
Recording video. We'll try to share, ma'am.
Well, sir, I need, sir, because I missed it out.
Yeah.
I missed it out the class, sir. I was waiting from so many days, and I'm the one who missed the class.
Okay.
So please try to send me that recording video so that I'll go through everything. And if I have any doubt, I'll get back to you back.
Okay, we'll try to.
Actually, it went out of my mind and I didn't intimate my patients that my class is there in so and so time. So they have come and I was not able to take up the class.
Okay, fine, fantastic.
Right. Okay, sir. Thank you, sir. Thank you so much.
So you have asked one question about the ligament. Need to go. Yes, ma'am. Please unmute yourself and you can.
Sir, you have asked that question about the ligament attachment, which have the strongest force transmission.
Yes.
So is it the like epiphyseal connection, like epiphyseal interface, because of the fibrocartilaginous structure present there, like in between?
So when the fibrocartilaginous structure is there, is it okay? It's easy for the fibrocartilaginous structure to get damaged, correct?
Okay. Yeah. Yes, sir.
So if it is a direct tendon or the ligament connect, is it stronger?
Sir?
I'm asking whether when there's a direct tendon connection, is it stronger? Or when there's a cartilage, it's stronger. Cartilage is something intermediate, right? So
yes,
when
sir.
two structures are connected.
The cartilage, sir.
Yes, ma'am?
I think with the support of the cartilage, it will be like much more injury prone. Injury will be the less if it is of support with the cartilage.
Yes, but when there is a in-between structure, it is going to have less effect. So because the cartilage can also get injured. When the bone is directly connected to the tendon Achilles.
Then it might pull the bone directly.
Yes, ma'am. Tendon Achilles is a classic example. So much of force is transmitted. For example, if you're a 70 kg individual and if you're going for a walk or a small jog, it's around 300 Newton or kgs of force is transmitted from the tendon to the calcaneum, correct? And is there any cartilage connecting the tendon Achilles to the bone or directly connected to the bone? So we need to find out whether the cartilage, how the tendon Achilles is connected to the calcaneum, correct?
That's what, since I missed it out most of the sections. Main part is that you are explaining in what is the fiber in between the cartilages, what are the other soft tissue things are which are helping out for the ligament, tendon and everything. That is the portion where I have missed it out.
Disilva from Sri Lanka, right? Fantastic. Nice to see some from India and from Sri Lanka.
The next time try to take on Sundays. So we have a lot of time on Sundays.
Sundays. Okay, I'm sure we'll plan for a Sunday.
Because we are not software, no sir. We don't have the Saturday and Saturday evenings and all. Even Saturday also it is a working for us. So Sunday will be a quite good for us.
Okay, ma'am. Future, we'll plan for a Sunday workshop.
Right.
And we'll connect with more information regarding this tendonitis and pathology. So we are just for an introduction session to make a little curiosity for the therapist is what I wanted to do, because there is so much to learn about the tendon and ligaments where we take it very easy. So without understanding the pathophysiology, now when you see this pathophysiology, we can know how to work on treatment protocols for this. So this is what I want to impart. So when we see an ankle inversion sprain, we need to see whether there's an retinaculum strain or there is a fracture or anything. So when you understand the host of pathologies, what all structures could have got injured, it's very easy for you to treat, and your recovery will be patient's recovery will be much better. Thank you. Any other questions from? Okay, hello sir, it was insightful. I'm waiting for the. So there is a message from Awaranjana De Silva. Hello, sir. It was very insightful, and I'm waiting for the future sessions too. Thank you so much. This topic is very interesting, where I'm struggling for some classes. Thank you very much, man. Thank you very much, man.
Lot of people are dependent on you, sir. Because your radiology class has helped me a lot. Now I'm able to identify. Every time I used to find only osteoarthritis. In front of me, only osteoarthritis, if not minor fracture, used to come. This is the basic knowledge which I have previously. But now I am able to diagnose more bigger things also. How the osteophytes are formed. Initially, I don't know how the osteophytes are formed. I simply tell there is osteophytes formation. But now it is the soft tissue injury which is forming the osteophyte formation and everything. This is the thing which I have learned it. So your sections are helping us very lots. So please keep on doing them some or another webinar, at least monthly 2 to 3 webinars we expect from you, sir.
The preparation of the webinar is long.
Of course, it is little tough, but it is helpful for so many people, sir.
Yeah. It takes time for us to prepare.
We are the juniors, sir. You have to help us.
So we have to put a lot of effort to do this webinars and everything, and it's very expensive also now. So we need to consider that also, because it's time constraint and we need to do a proper. So only when I consider the topic really useful and I know that in detail or prepared, then I'll take in a webinar. Till then, I'll be doing a lot of preparatory work for this. So along with my clinical practice, and this is
yes, sir. That's why we are ready to I don't think it in other ways. So we are ready to pay for the webinar, whatever.
Sure.
We are ready to pay. At the end of the day, we are getting the knowledge which is practical one, not the bookish one. So we need a practical thing which we are getting from you, sir.
For the rehab protocol, we will definitely make a webinar. We'll take a little time, because when I'm going to give something, it should be really useful for you in the clinical practice, and you should be able to appreciate that. So we need the preparatory phase is more for us to do that. We are developing a platform for this specifically. It's a learning module system. So once that platform is up and running, so we're going to put all these webinars in that one, so that people can come pay for that session and they can listen to the entire webinars multiple times. Also, they can get separate logins. So we're working on that platform. Nitu Gopi, thank you very much, sir, for the classes and learning many new things about tendon, ligaments, and about the PDS. Thank you very much. Thank you very much. I hope this will wind up with this webinar. And thank you very much for all your participation and questions in this webinar. In future, we will definitely meet with the tendon pathology or how to work on rehabilitation. So in this PDAC protocol, we saw the pathophysiology. We'll see the differential diagnosis and other factors one by one for the tendon itself first. We'll work on tendon and then we'll work on one by one tissue in the future. Thank you very much. Signing off.